Hello, this is Steve Bonsib coming to you from Arkana Laboratories in Little Rock, Arkansas. This is the second part of a six-part series of developmental abnormalities in cystic kidney disease. As you can see in the second line here, this presentation will discuss part one of congenital anomalies of the kidney and urinary tract, often abbreviated KCUT. First, just a few facts about developmental abnormalities in cystic kidney diseases. They are very common, affect 10% of the population. They come in a large variety and combination of abnormalities. This is partially depicted here in the image on the right, where I have a composite photograph of a variety of cystic kidney diseases. Hopefully by the end of this lecture series, you will be able to easily recognize all of these. Most of these diseases are renal limited, but a number of syndromes may have one of these renal disease as part of it. They are diverse in pathogenesis. Onset can range from prenatal to adulthood, and they are unfortunately the most common cause of end-stage kidney disease in children and the fourth leading cause of end-stage kidney disease in adults. And several of these have a neoplastic diathesis. There is no really satisfying classification of these diseases. I have two classifications shown here. Please don't try to read them. The font is too small. But they're just simply to indicate that most classifications are in fact simply tabulations of entities that are grouped into subgroups that have certain features in common. The one on the left was first published in 2021. The one on the right is my classification from 2010. I don't think mine is any better than the other one. Since that time, though, I've kind of simplified my approach to these diseases. And I currently think of them as falling into one of three categories. Two categories are based upon pathogenesis. The first category that we'll be discussing in this lecture, as well as this one to follow, deal with congenital anomalies of the kidney and urinary tract. This is a spectrum of embryologic perturbations of the kidney and lower urinary tract. In other words, these abnormalities are present at birth. The second group is the ciliopathies. This is a family of very diverse entities, and they have in common mutation of one or more genes encoding for proteins in the primary cilium. These proteins may also reside in the centriole and cell junction. And the third category is just kind of miscellaneous other entities, several of whom the pathogenesis is unknown. This table compares and contrasts KCUT and ciliopathies and forms the basis, the rationale for their separation. KCUT, the kidneys, are abnormal at birth in every case, whereas ciliopathies, most often the kidneys are normal at birth. KCUT can be unilateral or bilateral, and when it's bilateral, it may be symmetrical or asymmetrical. And by that I mean the abnormality may differ on each kidney lower urinary tract moiety. Whereas ciliopathies are always bilateral and always symmetrical. Urinary tract, lower urinary tract disease only occurs in KCUT, and both groups can have extrarenal anomalies as part of their syndrome. As you can see from the etiologies of KCUT are far more diverse than the etiologies of ciliopathies. This is a list of the KCUT malformations. In this and the subsequent segment to follow, I will discuss only the renal abnormalities. However, as you can see, KCUT involves the ureter, bladder, and urethra not uncommonly. And combinations of malformation is common, and as I mentioned before, bilateral discordance is also common. In the first segment, I asked the question about KCUT, are they rare diseases? And individually, they are rare diseases. And in fact, there is a definition of rare disease. The United States Rare Disease Act of 2002 defines a rare disease as affecting less than 200,000 people in the U.S., which is approximately 1 to 1,500, maybe 1 in 2,000, since it's over 20 years old. All cystic diseases and developmental abnormalities are regarded as rare by the European Rare Kidney Disease Network. Collectively, however, these diseases are not rare. And again, a quote from OrphanNet that I gave in the last segment: rare diseases are rare, but patients with rare diseases are numerous. They occur in 10% of the population. And if you look at causes of end-stage kidney disease in individuals below the age of 21, according to the United States Renal Data System Registry of almost 26,000 patients, 23% either have K-cut, autosomal dominant, or autosomal recessive polycystic kidney disease or nephronophthisis. By comparison, only 16% have primary glomerulonephritis and 14% focal segmental glomerulosclerosis. And although many of these diseases listed, the top 4 diseases listed may not come to a renal biopsy, they do represent the renal pedigree of many renal transplant patients. Now, K-cut etiologies are diverse, as I noted in the previous table. Approximately 10 to 20% are monogenetic, and of the monogenetic causes, PAX2 and hepatocyte nuclear factor 1 beta are the 2 most common genes mutated. However, there are numerous other mutations can also give rise to K-cut. K-cut are not uncommonly familial, and they're very important maternal, intrauterine, and exogenous causes. If we just look at genetic causes of K-cut, the K-cut phenotype does not predict the genotype. And again, don't try to read these tables, but listed in this table on the left, we have a K-cut phenotype listed here, and as you can see, there are numerous mutations that can give rise to an individual K-cut phenotype. Similarly, the K-cut syndrome cannot predict the phenotype. And here on the table on the right, we have a long list of syndromes in which K-cut develops, and here on the far right, there are the K-cut abnormalities, and although you can't read it with this small font, renal agenesis, for instance, appears in 10 different syndromes, renal dysplasia in at least a dozen different syndromes. Maternal and intrauterine contributions are extremely important because of their global incidence. If you look at low birth weight, for instance, over 20 million people are affected by that. Prematurity, 15 million. Going further down, gestational diabetes, over 21 million. Maternal obesity, 30%, and so forth. So these maternal and intrauterine contributions are extremely important, not only in the U.S., but also globally. Okay, let's discuss some of the individual K-cut malformations. I'm going to begin with 3 abnormalities: rotation abnormalities, fusion abnormalities, and renal ectopia. I find it useful to group these together because they often occur in combination. For instance, fused kidneys are always ectopic, and most fused and most ectopic kidneys are non-rotated. Although these are the most common of the K-cut abnormalities, fortunately, they're usually clinically insignificant. When complications develop, they're due to impaired urinary drainage. Thus, patients have hydronephrosis and may develop flank pain and are at risk for infection and nephrolithiasis. Beginning with rotation abnormalities, the definition is simply that the renal pelvis is not medial in orientation. When the kidneys initially developed, as shown in this diagram on the right, while they're down deep in the pelvis, their ureters are anterior. With growth of the fetus, the kidneys gradually migrate into the flank position and rotate to a medial orientation. The rotation abnormalities can be one of several types. Non-rotation with an anterior renal pelvis is far and away the most common. And this image here on the right shows an example of two kidneys in which non-rotation abnormality is present. Notice the renal pelvis and ureter in both cases are anterior, and the renal pelvis itself is dilated in both kidneys. Rotation abnormalities can also occur with over-rotation, in which the ureter is posterior or even lateral in location. These are very rare, and I've not seen an example of this type of rotation abnormality. Ureteropelvic junction obstruction may occur when associated with non-rotated kidneys if there are lower pole vessels. And if we look at the image on the far right, we have a normally rotated kidney with a medial renal pelvis and ureter. And on the other side, we have a duplex kidney with two ureters. And notice the lower pole ureter has lower pole vessels crossing it at the ureteropelvic junction, and we can see pelvic dilatation right here. Fusion abnormalities are simply kidneys that are continuous at some point in the renal parenchyma. Most often this is at the lower pole, the so-called horseshoe kidney. And here on the left we have a nice example of a newborn showing very prominent fetal lobation, fusion at the lower pole, giving the horseshoe shape. Notice the ureter and pelvis in both cases are anterior. This was associated with posterior urethral valves, thus the bladder is dilated and there's dilatation of particularly the ureter on the right side, the left kidney. Here's another example of a somewhat horseshoe-shaped kidney in which there is a much larger degree of renal fusion. Again, notice the ureter and pelvis are anterior, and this is the most extreme form of fusion in which we have a central midline mass, but with two ureters normally located in the bladder. So fused kidneys are always ectopic and usually non-rotated as well. Renal ectopia, that's simply failure to assume a normal flank position. The most common is retention of sort of the fetal location, namely within the renal pelvis. The kidney in the upper right is in fact a pelvic kidney. It has an anterior ureter, so it's non-rotated, and its blood supply is from the iliac artery and vein. The contralateral kidney was not present, so there was another K-cut abnormality, namely unilateral renal agenesis, and this kidney is hypertrophied in compensatory fashion. Kidneys can be located in other locations. They can be abdominal above the iliac crest. They can be just below the diaphragm associated with omphalocele, or they may be supradiaphragmatic, in which case the corresponding lung lobe is usually hypoplastic. And they can be crossed in the opposite renal fossa, in which case they are usually fused. The image on the lower right shows a cross-fused renal ectopia. Both renal masses are in the left flank, and we can see a crossing ureter going over here, the other ureter placed here. The patient also had a rectal vesical fistula. Next, let's talk about renal agenesis. Renal agenesis is most often unilateral, and it's defined as an absence not only of the kidney, but the ureter and the hemitrigone. Interestingly enough, the radiologists refer to it as a single kidney. I guess they see what's there, whereas we see what's not there. The reason why the trigone is involved is if we look at this diagram of the ureter as it approaches the bladder, it has an intramural and then a submucosal portion, which then leads to the ureteral orifice. The muscle of the ureter, however, fans out and extends beyond the ureteral orifice, forming the trigone. So if the ureter is not present, the hemitrigone is also not present. If we look at this image at the bottom, this is a gross photograph of an opened bladder. Here we can see the verumontanum, so the patient was a male. Right up here is the one ureter orifice and one hemitrigone, but as you notice we go to the other side, it looks much different, and that's because the hemitrigone is absent because there's no ureter or kidney. Now, unilateral agenesis may have a normal contralateral kidney, and if the contralateral kidney is normal, it should be hypertrophied. If it's not, it probably possesses one of the other K-cut abnormalities. 70% of patients also have ipsilateral genital tract abnormalities, which means if you have a single kidney, the genital tract should be examined on that side, and correspondingly, if you have unilateral genital abnormalities, the patient should be investigated for a single kidney. Bilateral renal agenesis is much less common. It's often referred to as Potter syndrome, and again, it's the absence of both kidneys, both ureters, and the entire trigone. It's more common in males. The mothers of these fetuses are affected by severe oligohydramnios. The reason for that is because most of the urine formed in the latter third of gestation arises from fetal urine. So since there are no kidneys and no urine, mothers have oligohydramnios. The babies are either born stillborn or suffer an early neonatal death from pulmonary hypoplasia. They develop pulmonary hypoplasia because fetal urine is required to be inhaled for proper lung development. And these patients also have a number of extrarenal stigmata, often referred to as the Potter phenotype or oligohydramnios phenotype. The image on the right shows an example of bilateral agenesis. Notice down here we have two testes, so the patient was a male. Most of the gastrointestinal tract has been removed. We have a little bit of the sigmoid colon and the rectum, stomach and proximal duodenum here. And notice the adrenals appear very large and somewhat more rounded, but the flanks on both sides are empty because the kidneys are absent. This is an example of the oligohydramnios syndrome or phenotype. It consists of Potter's facies, pulmonary hypoplasia, and positional deformities of the lower extremities. Potter's facies are shown in the two images on the right. That consists of low-placed, posteriorly rotated ears, recessed mandible, beak-like nose, which is very broad, and epicanthic folds. Potter's syndrome is not the only cause of the oligohydramnios syndrome because any situation in which there's no urine production, a similar phenotype will develop. So patients with bilateral multicystic dysplasia, which I'll be discussing next, have no urine production and therefore develop this phenotype. And some patients have normal kidneys but complete urinary tract obstruction and similarly have severe maternal oligohydramnios. There are rare other causes such as autosomal recessive, polycystic kidney disease, and renal tubular dysgenesis, which I will be discussing later. Okay, the final entity I'd like to talk about is renal dysplasia. Renal dysplasia is most often cystic in nature, and therefore some nomenclature of renal cysts I think is in order. First, the definition of a renal cyst. It's simply defined as a closed or communicating segment of nephron or collecting duct dilated to greater than 200 microns. A cystic or multicystic kidney is a kidney with 3 or more cysts, and cystic kidney disease is morbidity attributed to the cysts. Although we have these three sort of clearly defined definitions, however, we don't follow those rules very well. For instance, a tubule that's greater than 200 microns is only the size of a glomerulus, and if we had a biopsy showing that, we'd probably just call it an ectatic tubule. Early onset autosomal dominant polycystic kidney disease has very few cysts, and therefore no morbidity due to the cyst, yet it's called a cystic kidney disease. Similarly, in acquired cystic kidney disease, the main morbidity is the underlying non-cystic disease, yet we call it a cystic kidney disease. So although we have these clearly written definitions, we violate those definitions quite commonly. What is renal dysplasia? Well, quite simply, it's abnormality in nephrogenesis, in which we have undifferentiated metanephric kidney, and it can also involve ampullary bud derivatives as well. Although the word dysplasia is part of the lexicon, it's unrelated to neoplasia. There is a glossary of renal dysplasia based on degree of cyst formation and cyst distribution, and although these terms are not strictly applied, I have listed here the common usage of these various terms, and they're really just adjectives affixed to dysplasia. So for instance, if the kidney is large and cystic, multicystic dysplasia is usually employed. If it's small but still cystic, often it will simply be called cystic dysplasia. If it's small and non-cystic, then it's referred to as an aplastic kidney, aplasia, or aplastic dysplasia. All of these have in common lower urinary tract abnormalities of one of several types. Now, unilateral dysplasia is fairly common, and like renal agenesis, is often associated with ipsilateral genital anomalies. Bilateral dysplasia is much less common, and those patients present with maternal oligohydramnios and early neonatal death due to pulmonary hypoplasia. There are segmental forms of dysplasia in which half of the kidney is involved, and it's usually the upper pole of the duplex kidney. And there are focal forms of dysplasia in which you have an admixture of normal and abnormal nephrons. And I will illustrate examples of all of these to follow. Here's a group of 4 gross photographs. The one on the upper left shows a unilateral multicystic dysplasia. This was discovered in a 90-year-old male. The contralateral kidney is normal but hypertrophied, and this was an incidental finding. In the upper right, we have an example of bilateral multicystic dysplasia in which the kidneys are massively enlarged, and the thoracic cavity is compromised because of a combination of the mechanical effect of the large kidneys as well as the fact that there was no urine produced, therefore pulmonary development was impaired as well. This is an example of a small kidney with cysts that we could refer to as cystic dysplasia. And here on the lower right, we have a dysplastic nubbin of tissue with no cysts. So this is renal aplasia or aplastic dysplasia, and this was associated with vaginal ureteral ectopia. As I indicated previously, renal dysplasia usually has severe ureteral abnormalities, and I have 2 images that show 2 extremes. The one on the left shows severe atresia of the ureter with bilateral cystic dysplasia. The middle image shows marked hydroureter with a rectal vesical fistula. The kidneys themselves are very small. Notice how they are dwarfed by the overlying adrenal gland. And the image on the right shows a cystic dysplasia and a hydronephrotic kidney. Again, showing the bilateral discordance of KCAT abnormalities. Microscopically, renal dysplasia shows a very diverse array of findings, but there are 2 features that are sort of classically identified as features of a dysplastic kidney. The first is immature cartilage, and we can see on the left here a couple of islands of immature cartilage. Similarly, in the middle image, 2 islands of immature cartilage. Although they are characteristic of dysplasia, most dysplastic kidneys will not have this feature. Much more commonly are the what are referred to as immature dysplastic ducts. These are believed to be ampullary bud derived, and they are collecting a duct-like tubule with collarettes of spindle cells. And these spindle cells, curiously, co-express estrogen and progesterone receptors for reasons that are unclear. Now, each case of dysplasia is morphologically unique, so I have 3 images here just to demonstrate the variety. The one on the left shows a number of moderately sized cysts with very little intervening metanephric tissue, just a few immature ducts. The one in the center shows lots of immature or dysplastic ducts with some immature remnants of poorly formed nephrons in the background. And on the far right, we have cysts, and then we have a couple glomeruli that look relatively well formed, but lacking any significant tubular component. And here we have a glomerular cyst in which the glomerular tuft is splayed along a portion of the Bowman's capsule wall. Sometimes dysplastic tubules will show a significant degree of differentiation, and in these cases we have prominent corticomedullary differentiation. If we look at the left, we've got nice cortical tissue here, medullary tissue here and here, but unfortunately none of this is connected to the collecting system. Here in the center we have cortex with many normal appearing nephrons and a few microcysts, and yet the renal medulla is very rudimentary in formation. And here on the far right we have the deeper nephrons, or the earlier formed nephrons, appear fairly normal, whereas the dysplastic features are confined to a row of the outer cortex and the column of Bertin, representing the more recently formed nephrons. Here's an example of segmental dysplasia, which occurs in a duplex kidney. This duplex kidney is very abnormal. There's the upper pole ureter here, and the upper pole renal moiety has cysts and dysplastic elements as shown here on the right, with dysplastic tubules and then aberrantly formed nephrons in the background. The lower pole moiety is affected by obstructive uropathy, and we can see here marked hydronephrosis, and that was because of a distal ureteral obstruction. Here's another example of a segmental dysplasia, this one occurring in a fetus. We can see here the nice nephrogenic zone of the early fetus. This is the lower pole of the kidney. The upper pole of the kidney, however, has cysts, many of which are glomerular cysts, with again some rudimentary metanephric tissue set within a very loose spindle cell stroma. Here's an example of focal renal dysplasia, in which we have many normal appearing nephrons here, but then we have this island of dysplastic tissue, probably representing lobar dysplasia. And finally, here's an example of focal dysplasia in a needle biopsy. This was from an infant with chronic kidney disease and small non-cystic kidneys. And although we see prominent cyst formation here at low power, imaging studies usually require a cyst to be 2 millimeters or more to be detectable, and these are probably 1 millimeter in diameter, so too small for detection. Nonetheless, we have a glomerular cyst right here and a small glomerular cyst here. We have some immature metanephric tissue up here, and we have an occasional glomerulus that looks well formed with normal appearing proximal tubules. So an admixture of mostly dysplastic nephrons with some seemingly normal, relatively normal appearing nephrons. As I indicated, K-cut can be syndromic or non-syndromic. This is just a short list of the many syndromes in which renal dysplasia can occur. And although HNB, hepatocyte nuclear factor 1 beta, and PAX2 are the most common monogenetic causes of dysplasia, many other genes, some of which are listed here, can similarly cause a dysplastic kidney. And one cannot tell renal dysplasia in these syndromic and or monogenetic forms from sporadic forms of renal dysplasia. I'll just illustrate two examples. This is an example of Meckel-Gruber syndrome, where we have a multicystic dysplastic kidney here. The microscopic is shown here. It's mostly cysts with very few metanephric derivatives. And here's a separate case, a different case of Meckel-Gruber syndrome, in which we have rudimentary corticomedullary differentiation with large medullary cysts. The cortex has a few relatively normal appearing glomeruli, but no tubular components to those glomeruli. And finally, here's an example of Zellweger syndrome with a diffuse multicystic dysplasia here on the left. The two images on the right show some normal nephrons, but then dysplastic elements sort of admixed with the normal nephrons. So both showing examples of focal dysplasia. Well, this concludes part one of KCUT. Part two, the next segment will review predominantly renal hypoplasia. And if you would like sort of some initial insight into my perspective of renal hypoplasias, I can refer to you to this review article I published in 2020, which you may read in advance of the subsequent lecture. So that concludes part two. I hope you will also tune into part three, which will follow shortly. Thank you.